Mike Eppinger. I recently retired from the Air Force. I'm a cardiothoracic surgeon. I spent my last 2 years in the Air Force at David Grant Medical Center at Travis Air Force Base in Northern California. And now that I'm retired, I'm working for the Audie Murphy VA in San Antonio as the Chief of Cardiothoracic Surgery.
So I'm Dave Johnson. I'm a 28-year veteran. So I work for VA Northern California at the Air Force's David Grant Medical Center in their joint venture program office.
I'm Scott Hundahl. I'm the Chief of Surgery for VA's Northern California healthcare system, and I'm a professor of surgery at UC Davis. We started the relationship actually with some successful sharing agreements. We started small, identified low-hanging fruit, and through a sharing agreement, did a mutual alignment that made financial sense and programmatic sense. Through that process, we began to learn about what worked and what didn't work. And what worked for us actually was abandoning merged structures in favor of alignment, purposely avoiding disruptive change so that we could simply align our strengths, match them with our partner's weakness and vice versa, and develop a track record of success. And with each program that we added, our confidence improved, momentum improved, and then of course the GIF grant mechanism helped quite a bit.
Correct. So I would say, since we're both medical centers, we have a bigger depth of specialty platforms. And with the Air Force's David Grant, they really had a large structure to pick from. So when we looked at alignment, really what was the low-hanging fruit? And part of that is the excess capability and capacity. And the majority of that was really in the surgical specialties. I would say, however, in the outpatient arena, we did get aligned pretty early on with programs with radiation oncology. Maybe that was part of the GIF process, which allowed us to buy some capital equipment with a second linear accelerator. I think that was probably the limiting factor. We had plenty of radiation oncologists, but if we had a second room, we can actually pump them through. And then we also kind of look for a lot of our surgical specialties that Dr. Eppinger.
So I think that it's important, and one of the questions after the session was how do you convince people? And it's different on the VA side of things and on the DoD side of things. So, there are different goals for each of those systems in terms of what they need to get out of it. The VA has plenty of patients and doesn't necessarily have all of the resources to take care of them. And on the DoD side of things, we tend to be, the way that the DoD medical centers are resourced is way in excess for a peacetime mission. We have personnel so that we can deploy them, but if they're not all going to be deployed, they have to be kept busy in garrison. And so from the DoD side of things, it comes down to, it has to be framed in terms of how is it going to benefit the DoD. For us, it's a readiness issue. The more patients that we can take care of, the busier all the docs and nurses and techs and the entire hospital structure is, the more those people are ready to deploy and go do their downrange job, which is what the government is paying us to exist for.
And these programs create a very convenient buffer for both the VA and the Air Force. Clinical buffer, you mentioned times when everyone is deployed, and how do you keep treating the folks who are back here in the continental U.S., and then also a financial buffer during times of fiscal stress, and we've both experienced that. When cash is short it's nice to have a buffer of real money under local control that can be applied to service a clinical need or develop a program, or that local control of real money becomes quite important.
And I would like to go back to your point about healthcare being local. I remember a few Air Force Surgeon Generals ago, it was like all healthcare is local. And being designated a joint venture site really gives us management governance to kind of pick and choose what's our local capacity, what's our local demand, and really go for it. We go for it, just on the margin. If I brought an extra doctor, how much more throughput? And it really, it keeps our eye on the short-term horizon, what our local needs are today, and also projecting forward, I think, what's going to come next.
It's interesting because when you look at some of the more elite subspecialty care, the VA patients allow you to have a big enough patient volume to really expand your capabilities, and actually allows the Air Force to recapture some of the DoD beneficiaries that are otherwise we wouldn't have the expertise to take care of. So, you build like at Travis Air Force Base, an integrated heart-lung vascular center with cardiology, interventional cardiology, electrophysiology, vascular surgery, cardiothoracic surgery, pulmonary medicine, and you can't have all of that working together without a lot of high acuity patients. As you bring in more VA high acuity patients, you expand everybody's expertise, and now those patients on the Air Force side, the DoD beneficiaries that otherwise we may have to send out, now we have the capability to take care of them at David Grant. So especially on, you look at one specific example, electrophysiology is a very, very expensive thing to send out for care. And being able to recapture that care not only improves everybody's expertise, but it saves the system a lot of money.
Our initial fixation on doing a joint program as a merger, and we learned through the sharing agreement experiences and our initial drifts that, wow, if you do it as a merger up front, given some of these barriers, electronic medical record system differences, the differences in population, very difficult to do. It seemed if we had pursued a merged structure for a joint program, we would never get it off the ground.
Whereas there's more leadership distaste for that as well. So the two systems, they're different systems. The patients are different, the goals are different, and if you allow those two to really augment each other, and you say, no, the VA isn't losing its identity. Mm-hmm. The Air Force is not losing its identity. We're all working to take care of the patients in one facility, but the VA nurses are VA nurses, and the surgeons, they're Air Force surgeons, but everybody's they maintain their identity, but they're all working towards a common aim. So.
It takes so much complexity out of the equation if one simply aligns.
Trying to identify who's in charge. But I think back to the point, what makes for a successful relationship, and it really is at the clinician-physician level, is you have to have that leader championship at that level. The senior leaders could have a vision. I want to start this because I want to save money. But if it's not at that flight chief level or chief of surgery, something like that, there's no momentum, there's no enthusiasm, and it just kind of dies on the vine over time. If you don't have that.
We've been very lucky in terms of personnel, in terms of hospital commanders,
yes.
And we've had some real fans. I mean, I think Brian Hayes was almost a cheerleader for this sort of relationship.
Yeah.
And it helps to have fun people to work with.